Everybody, and welcome to St. John's Cancer Institute's Be Inspired Speakers Series, The Genetics of Cancer, Exploring Genetic Testing and the Path to Treatment. My name is Gene Goldsmith. I'm a Director of Development at St. John's Health Center Foundation, and I'm very happy to be here today. This is the second of two webinars on the genetics of cancer. The first was held on February 17th, and if you were unable to join us and would like to see a copy of that webinar, we're very happy to send that to you. So please just let us know. You can send an email to us, and we'll be happy to send you that link. St. John's Cancer Institute, formerly the John Wayne Cancer Institute, has been a part of St. John's Health Center for over 30 years. We are renowned for our groundbreaking research, pioneering surgical techniques, and bench-to-bedside translational medicine focused on major areas of cancer research, immunotherapy, molecular medicine, and precision medicine that comes from analyzing each person's genetic markers that allows us to target treatment individually. St. John's Cancer Center is also home to the Donald L. Morton Complex General Surgical Oncology Fellowship Program, one of the oldest programs in the nation that trains the next generation of surgical oncologists. Our fellowship program has graduated over 150 fellows that lead programs and are deans of departments at major cancer centers all over the country. We've also have international research fellows that train with our senior researchers from 1 to 4 years. And Dr. Dave Hoon, who is on our panel today, is the person who does that training. So you'll hear a little bit about that today as well. Because of this academic level educational programming and world-class research, St. John's Health Center is in a unique position as a hybrid community academic-based hospital offering patient-centric care and academic level education and research. We also provide fantastic community education, and you're hearing some of it today. Before we get started, I have a few housekeeping items that I'd like to share with you. We would love to hear your questions. As you will notice, everybody but the presenters are muted so that we will all be able to hear them well. In order to ask questions, you will need to use the chat function on your screen. The chat function is located on the bottom of your screen, and it looks like a thought bubble. We will see your question and make sure to ask the physician or researcher. And if we don't get to your question during the webinar today, we will follow up with everybody with answers to these questions for everybody to see, and that will be in an email form. Please note, we cannot answer specific treatment questions, but we're happy to answer general questions on the subject of the webinar. We will be recording the webinar today, and it will be available on the Cancer Institute website. And we will also be sending out a copy of the recording to you via email after the webinar is done, probably in about 3 or 4 days, if you would like to forward that to anybody. We have a very interesting hour in front of us, as we will hear from a clinical geneticist, a research scientist, and a surgical oncologist who specializes in the use of genetics in their medical practice and research. I'm very honored to introduce the panel today. Our first panelist is Dr. Ora Gordon. She is a nationally recognized expert in hereditary cancer and the medical director of the Regional Center for Clinical Genetics and Genomics for Providence, Southern California. She is the clinical director of the recently established Providence St. Joseph Health Population Genomics Program and a principal investigator for the system-wide Genome for Me study. Dr. Gordon is board certified in internal medicine and medical genetics. Her primary research interests include identification of hereditary cancer in the general population and individualizing risk for common disease. Passionate about the holistic approach to medicine, she's also completed a fellowship in integrative medicine, and that helps to expand options for primary prevention and nutritional research for high-risk patients. Dr. Gordon has co-authored an award-winning book for women facing genetic risk for breast and ovarian cancer called Positive Results, Making the Best Decisions When at High Risk for Breast and Ovarian Cancer. Our second panelist today is Dr. Dave Hoon, a senior researcher at the St. John's Cancer Institute. He is the director of the Center for Translational Molecular Medicine and a professor of genomic sequencing. Dr. Hoon interacts with external academic, industry, governmental agencies, and international cancer centers to develop innovative translational cancer research opportunities. He has over 30 patents on his studies and has co-authored over 350 peer-reviewed articles and reviews, primarily related to translational molecular oncology of human solid tumors. Dr. Hoon pioneered investigations of circulating tumor cells. We're going to hear about that more today, and cell-free DNA messenger RNA biomarkers for monitoring cancer in patients in phase 2 and 3 clinical trials. And that focuses on melanoma, breast cancer, GI cancers, and brain tumors. He directs, as I mentioned earlier, he directs the research fellowship and has trained over 80 doctors, PhD fellows, and graduate students in his lab. Our third panelist and moderator today, and thank you for moderating, Dr. Linehan, is Dr. Jennifer Linehan. Dr. Linehan is a board-certified urologist, a surgical oncologist specializing in genitourinary care, and an associate professor of urology and urologic oncology at the St. John's Cancer Institute. Dr. Linehan came to St. John's from the City of Hope and is an expert in robotic and laparoscopic surgery, male and female voiding dysfunction, and treatment for kidney stones. She's committed to personalized patient care and works closely with multidisciplinary teams to ensure the best experience medically and personally for her patients. So thanks so much for moderating, Dr. Linehan, and take it away.
Thank you so much. So good morning, everyone. We are here today to discuss a very important topic, and that's really genetics in medicine. And I will tell you that even to a surgical oncologist like myself, who spends a lot of time working with Dr. Gordon and people like Dr. Hoon, you know, it still can be confusing because there's many ways to get the data you want. There's many ways to interpret the data you have, which is really what Dr. Gordon specializes in. So we're going to start with Dr. Hoon today, who's going to tell us a little bit about understanding the differences between liquid biopsies and circulating tumor cells and cell-free DNA, and understand how knowing that information plays into both prognosis for patients, treatment for patients, and the most important, prevention, and how Dr. Gordon then uses that data that she gets from Dr. Hoon and scientists like him to help patients. So let's put up Dr. Hoon's slides and we'll have him go ahead. So Dr. Hoon, the first question is yours. And what are liquid biopsies? What are circulating tumor cells? And what is cell-free DNA? And what is the difference?
Thank you, Jennifer. So this is just a cartoon that we published a while ago. And the term liquid biopsy, you probably hear it in scientific journals, you hear it in the news, you hear it among various investors and biotech and pharma companies. So basically is that we discovered years ago, tumors like this represented here, release in the bloodstream, circulating tumor cells. So they were released in the bloodstream, some die, but some spread, so-called metastasis to different organs, and that's what eventually can kill a patient, eventually when those metastases increase. But they also release circulating DNA, which we pioneered here at the Institute, which can be in different forms. Most common that you probably hear are mutations and other like methylation and other forms. So these are very valuable markers now compared to the existing previous old clinical chemistry analysis in detecting tumors more accurately. And they cover almost every solid tumor now to this date. So it's quite extensive. So how we use it with Dr. Gordon, we use it for early detection in primary pancreas cancer. She screens out high-risk pancreatic cancer patients, and we assess these for reoccurrence using circulating DNA markers. For Dr. Linehan, we do both blood tests for circulating DNA and microRNA in both blood and urine for looking at renal cell carcinomas and also in prostate cancers. So those are the applications that we use.
So Dr. Hoon, tell the audience, and if you guys can put the slide back up. So if our audience is watching, if you put that slide back up for us, I don't know what happened to it. Or I don't know if the audience can see Dave's slide, but on the inside, so this is a blood vessel essentially here, okay? So in the blood, there's many different things that we can use to try to figure out, if the patient has metastatic cancer or if there's cancer there to begin with. And so you can see there's CTCs, which are circulating tumor cells, okay? And there are cell-free DNA. So Dave, tell the audience, what is the difference between finding a cell-free DNA sequence versus a circulating tumor cell, and why is that important?
So it's a good question. Circulating DNA tumor cells, CTCs, tells you that you actually have, as we diagnose it, we isolate and diagnose it through molecular approaches, it tells you that the tumor is present. So if you have the tumor removed and all of a sudden, maybe months later, these CTCs are present, that means the tumor is somewhere in your body, likely a metastasis. But it actually tells you you have a tumor where the cells are spreading. And so that's important. The circulating DNA or nucleic acids tell you that the tumor is present somewhere, but it doesn't tell you if it's spreading or not. So it's more of a detection. But what it does nowadays is, instead of doing biopsies, let's say in the liver or the lung, if we have certain circulating DNA with mutation markers, we are starting to come to the age where we can start triaging patients into particular targeted therapy instead of having to go through the biopsies, because we know that mutation is from that cancer of that patient, and it is what we call actionable. So this is starting to come more into play, and it allows for immediate treatment rather than go through a biopsy, which could be very morbid.
Okay, now, Ora, I'm going to skip to you for a second, because explain to the audience, you hear a lot of different, you hear the word epigenetics, you hear somatic mutations, you hear germline mutations. What do all of these different words mean? Epigenetic, somatic, germline, and how does that feed into what Dave does?
So that's so important to distinguish. And I think that even those of us who are professionals spend our time with cancer genetics get jumbled up in our head about which is something that we're born with versus what is the genetics of a tumor, and how do we distinguish those, and how do they influence each other. So kind of the flip side of what you just saw on that slide. So that is a slide looking at the DNA and influences on the DNA in terms of changes, mutations, things that get silent, things that get activated, all related to the genetics of the cancer itself. The germline are the cells that you're born with, right? That you inherit. You get all the cells from your body inherited from your parent, a mother and a father. And if there is a genetic change, a mutation, or what we now call a pathogenic variant, then that means that you have inherited a risk in all of the cells of your body to develop cancer or heart disease or any other genetic susceptibility that we can test for now. It doesn't mean that you have anything right now, or for the most part, it doesn't mean that you even have a guarantee that you'll get cancer. So the epigenetics and the environment and life and age is what happens when that first step forward in the long line of things that have to happen for a normal cell to become a cancer cell. When you have a genetic susceptibility or a germline change, you've sort of taken that first big leap forward. But there may be 10 to 100 things that have to happen before that cell loses control of itself and becomes a cancer cell. So that's the kind of things that we're looking at. We look for a germline change to say, are you at risk? Then if you are at risk, we're using all these technologies, blood liquid biopsies to early detect cancer. to look at prognostic, to look at how should we treat you? Can we leverage that genetic change that you were born with that we know is a really important thing that led to that development of cancer to treat you differently? And we're doing all of those things.
So epigenetics is sort of the study of all of this together, or?
So epigenetics, so if you think about anything like when actually the root of the word epi, right, is either at the center or above. That's sort of how, right? So epigenetics are the things that overlay on what you were born with, on the sequence pattern itself, to make things turn on, turn off, go faster, to make it invisible to perhaps things like your immune system. That's everything that we sort of talk about related to epigenetics. People worry, and there's a lot of work on, for example, nutrition and how nutrition might may influence the epigenetics, like your microbiome, changing how the DNA sequence, which looks the same, may be turned on or turned off, or environmental exposures and your, whether or not you've been exposed to tobacco, and those sorts of things are epigenetics, which can influence the sequence. Doesn't change, but whether it turns on and off or works faster, slower, or not appropriately is the epigenetics.
So the somatic mutation is the mutation that's in the tumor.
Exactly.
Correct? And the germline mutation is what you look for in the genetic testing you do maybe in blood or in saliva sometimes. And that gives you the sense that the patient has this gene risk, but there's no telling whether that will turn on and off sometimes.
Exactly. It's being at risk. You think about, and then even though those words. So, and then when you think about it, oh, well, I did a blood test for genetics, right? Well, was that a blood test for looking for cell-free DNA? Was that looking for identification of cancer that is present in your body? Is that looking for your normal cells to see whether there's a genetic change that puts you at risk? So even just knowing what test you had doesn't always tell you doesn't help you understand what exactly, because the experience feels the same for a patient. So if you have cancer and you're getting serial blood tests, you're getting some form of probably liquid biopsy that Dr. Hoon was talking about. So a cell-free DNA looking for circulating tumors to really say, is this cancer come back? Has this cancer changed such that we need to change our therapy for it? The germline changes are, in general, in people who don't have cancer or don't have another genetic disease, and they're looking to see, are they at higher risk? And then can we leverage that to screen them and do preventive interventions that will keep them from ever getting cancer?
Got it. So Dr. Hoon, let's take the conversation back to you now. So there's a lot of companies out there that are starting to do more liquid biopsy testing, looking for circulating tumor cells and cell-free DNA. And so one of the questions that I got from the audience was, can you go and request your doctor to do these tests? And yes, there's ways to do the testing. There are companies that are doing the testing. We do a lot of testing through our research facility. And while these tests aren't necessarily quote unquote FDA approved, they are done with Dr. Hoon, and he is looking for the circulating tumor cells in very similar ways that there's sort of these mass productive tests are doing. But perhaps on his end, they're much more specific to that individual patient. But Dr. Hoon, tell us, when you're looking for circulating tumor cells or you're looking for cell-free DNA, do they give you information about the mutations that are causing the cancer, or just that the patient has the cancer?
So it's a good question. So let me answer it in different parts. So some of the early tests that we developed, circulating nucleic acids, which can be DNA or methylated DNA or loss of heterozygosity. Some of these are FDA approved. There are now multiple companies that are FDA approved. Your physician would probably know them, and they can, like most of them are covered by HMO, and so that you can get the test done. Now, what we do is we continually develop other assays to improve this, because sometimes mutations, certain cancers are what we call low mutation frequency. So we have to look at other forms of DNA, such as microRNA or even methylated, which we do. So we're constantly making this. So at the end of the day, you want to be greater than 90% sure when you do a blood test that you're going to get. There are certain cancers, I said, that are high mutation and some are very low. So when you have those ones that are low, you need alternative forms. So that's what we do. And also then it adds another dimension is personalized medicine. Individuals can have certain mutations or methylations, signatures in their tumor that very few other patients of the similar cancer have. So then we can routinely follow them for the rest of their life. You may have a mutation in a particular gene that very few other patients do, but it's your signature marker of your cancer that you can follow the rest of your life. So it's constantly evolving and improving. I've been in this field. We first started in the mid 90s and it got into clinical FDA approval about only less than 4 or 5 years, but we're constantly improving. But it definitely improved diagnostics and monitoring therapies now.
So for the audience, I mean, you can look for the circulating tumor cells. You can look for DNA sequences that are just floating around. You can look for RNA sequences that are floating around that were made by microRNA that were made by those DNA sequences. You can look at proteins that are floating in the blood. And there's lots of different things Dr. Hoon can look at to help better understand someone's cancer and figure out if there are certain mutations that can help Ora, Dr. Gordon, figure out if there's better treatment options or better ways to watch the patient.
Right. So we call all those different assays, you say, we call it omics. Before, it was only very simple clinical chemistry proteins. But now we have a series of these molecular tests, as you indicated, that are multi-omics. So now, a simple blood test is like a forensic scientist. You do a blood analysis and you can get so much information of the cancer, that it's there, and what it's doing. Is it not just detection, but is it changing and progressing? Therefore, you would have different strategies in treatment.
Let's talk a little bit, and Dr. Linehan, and this is a question that sort of came up in the chat, but so let's even think about rolling that back. And then after I ask you this question, then maybe we can also then talk about how we're leveraging this for really early detection and kind of taking that same technology and saying, can we move this to a patient who doesn't know they have cancer and find cancer, the ultimate, sort of holy grail as we talk about. But for Jen, when you think about how are you using tests like this in the urine or in the blood for a patient who you're not sure, you see something on they've had either a little bit of blood or they have something in a kidney or the question is related to the prostate, and there's a lot of testing that can be done to help distinguish cancer from non-cancer. Can you speak a little bit to use how we're using sort of genetic information, signatures, multi-omics assays to try to say, this is actually something that's benign, even though your prostate's really big, or even though you have a kidney lesion there, we're not worried about it.
Right, so I think over time, we've all found that different cancers, you can use different markers in different modalities to really figure out whether they're there. So in the 90s, everyone was using the PSA blood test for prostate cancer. It was the first blood marker that we had for any urologic cancer, and still that's the truth. So that was the only thing that we really had. And then after the PSA test, they came out with more stratified blood markers that were based off the different proteins associated with the PSA, which is the PSA is just another protein that's in your blood. And from there, they pushed on into looking for what Dr. Hoon was talking about, which was talking about the DNA methylation on genes and specific mutations in genes, not the gene themselves, but the mutation in the gene that they could find in the cells from the prostate in the urine. So it was a urine test that looked for DNA mutations. So that was another way we could help diagnose if someone had prostate cancer. And now there are more blood tests looking for circulating tumor cells that are coming out for prostate cancer. But a lot of cancers, like prostate, unless they're really aggressive, sometimes you will not find enough circulating tumor cells to make it worth their while to do those testing. So the urine test has actually been better for prostate cancer. Now, the same thing with bladder cancer. Bladder cancer also has a lot of, there's probably 10 different urine tests, 10 for bladder cancer, all based off of different mutations in the actual cells, different markers, little receptors that pop up on the cells, and different proteins that these cells produce that can show you whether or not the patient has bladder cancer. And again, for bladder cancer, if you have patients with advanced cancer, the circulating tumor cells can be really, really helpful. And why that's so interesting to all of us and such a cool technology is if you could get a circulating tumor cell, so you know it's an aggressive metastatic cell, you can send that off for sequencing. And I'm going to kick this back to Dr. Hoon to explain next-gen sequencing to us. And then when they do the sequencing, they can look for the mutations. And from those mutations, Ora can tell us sometimes what treatment options are best or what the next best steps are. The only GU cancer that really doesn't have a lot of great blood or urine tests yet is renal cell. So for prostate, we have great blood tests, we have better genetic testing, we have circulating tumor cell testing, and we have urine testing, plus the PSA and MRIs and imaging. And then for bladder cancer, we have imaging plus 10 different urine tests and a blood test. And renal cell carcinoma, we're still working that out in the middle.
Yeah, so the advances of CTC in the first, I mean, we were the first to start doing molecular analysis of isolated CTCs. Before, still people do is antibody staining. But when you capture these CTCs, now that we can do sequencing of single cells, we can have a better definition of the signature, be it mutations, be it methylations or deletions. And we can now map these out from a very few cells, which we couldn't do 5-10 years ago. So this is where the technology has gone for circulating tumor cells, that we only need a few cells and we can map them out. And so this is applicable to all the GU cancers, bladder, renal, and prostate. And the fact that we can do urine, because those cancers all drain in early stages into the urine, that we can have a greater chance of collection. Rather, at the very early stage, if they're in the blood, they get diluted. So it's much easier to collect early stages. But once they spread systemically, we call it, to different organs, then a blood test becomes more powerful.
So Ora, for prostate cancer, why did knowing someone had a parent with prostate cancer or a parent with breast cancer start becoming important? I mean, when I started my residency, we never used to even ask if your mom had breast cancer. If you had a patient you were trying to figure out about prostate cancer. So why did that change?
So in all of the hereditary cancer space over the last 5 to 6 years, and we started to understand that so much of solid cancers, so much of kind of all tumors have a pretty significant underlying genetic susceptibility is the reason why why the cancer occurred. And we used it particularly in prostate, and all the things that Dr. Hoon is talking about is not specific to GU cancers or prostate or bladder kidney cancer. We have the expertise of Dr. Linehan, and the access to looking at those specific genetic changes is different in GU than it might be in pancreas or it might be for ovary. And so we use the same kinds of technologies and leverage them in the best way that's for that cancer. But about 15% of advanced prostate cancers have an underlying germline genetic change. That person was predisposed, they were susceptible. So we started to look at those hereditary cancers and say, well, should we treat them differently? And there are now targeted therapies, the same thing we're talking about with precision medicine, that there are therapeutics that the cancer, the reason why you got the cancer is the same thing that makes us able to exploit that and kill the cancer and not hurt your good cells. So this has really changed how we approach, and there's a whole category of medications that is effective for people who have BRCA or BRCA mutations, which drives high-risk prostate cancer, as well as breast and ovarian cancer, that all of those tumors, although they're in different parts of your body, can be treated with the same medication, with a high degree of efficacy. So it's really important to know if those are cancers that came from a germline risk or not. The same thing with like hereditary colon cancer, we do the same thing. That connects the GU cancer, so a kidney cancer or a cancer of the collecting system, what we call urothelial, with colon cancer, uterine cancer, ovarian cancer. That whole condition is called Lynch syndrome. And you wouldn't necessarily think, wow, my mom had ovarian cancer and my brother had kidney cancer. Do those things go together? Because they're not the same cancer, right? And so people tend to think, well, everybody has to have the same cancer for it to be important for somebody else in the family or that person getting another cancer. But we really look at all cancers together. And then there are patterns that we see that say this is very suspicious for a germline cancer, or this is less suspicious. But the testing has become so readily available and so accessible that we've sort of brought the floor, I don't know, the ceiling down or the floor up, that anybody who has a family history, quite frankly, for the most part, can access genetic testing. There are very strict guidelines still in terms of, whether your insurance will pay or not pay, but because the very high quality genetic testing for the germline can be done for about $250 for most people. And then the labs are very good about, even if there's financial hardship. So I tell people, don't think that any longer, you should not be thinking that, well, germline genetic testing or risk genetic testing doesn't apply to me, or I shouldn't do that, because the more we test is the more we learn, is the more we find.
Absolutely. So I want to kind of branch pancreatic cancer. We had some questions from the audience. So I know that you and Hoon have been working together very closely on a project with pancreatic cancer. Can you tell us what you've been doing, and then Hoon will hear from you as well, Dr. Hoon?
Sure. So one of the great things that we have developed at St. John's and for the region, for kind of patients and families all within the Southern California region, is a pancreatic high-risk program. And these are patients who are identified as carrying a genetic susceptibility to pancreas cancer. So they have a BRCA mutation, or they have Lynch syndrome, or they have another gene that's specific to pancreatic cancer, or they come from strong family histories, but we didn't find anything in that person who is well, but they have 2 or 3 family members with pancreatic cancer. So there are 2 things we do. One is everybody who's involved in that program is participating in giving samples so that we can try to track them over time to look at the unique signatures. This is Dr. Hoon's lab saying, can we find a unique pancreatic signature to say, we're finding this cancer before you would otherwise ever see anything on an MRI or an endoscopic ultrasound? Can we detect something in the blood that is the earliest thing? The other is the high-risk screening. So people who meet threshold for screening, we start to alternate an endoscopic ultrasound, which is like doing an upper endoscopy, as if you had reflux, or we're checking to see if you had an ulcer or H. pylori, and they put a specialized ultrasound on there. And we have expert gastroenterologists at St. John's that do that. It's additional fellowship. Not every GI doc can do an endoscopic ultrasound. And then we alternate that with an MRI, a specialized MRI of the pancreas, each one once a year. So that's how we follow our high-risk patients. The other thing that's been exciting, so in addition to everything that Dr. Hoon's lab is looking specifically to find markers, is that we're now offering the new commercially available Grail gallery test to all our pancreatic high-risk patients. And this is the same thing. This is looking for cell-free DNA, unique signatures in the cell-free DNA to say, do you have cancer and where is that cancer coming from? And so this is a single blood test to detect not only pancreatic, but up to 50 types of cancer at the same time. And maybe Dr. Hoon wants to speak a little bit about that, because it's both very exciting, but there's still much to be learned about using a blood test to say you have cancer in somebody who otherwise has no signs and symptoms of cancer.
Yes, Ora. So again, as I said earlier, mutations are one of the key signatures of some pancreatic cancers, but they don't have all the mutations. So we look at other markers such as microRNA, which we've been quite successful at, and methylated DNA. So going back to what we say, we try to do an omics approach, especially on early cancer, because you get very little amount released, but you want to capture everything. So we have what we call a bigger fish net for looking for those we call rare events. And that's our approach. It's not just use the standard DNA markers, but others for pancreatic cancer, so that by doing repetitive tests, if we miss it on one time, it doesn't mean the tumor cells are not just constantly releasing these factors. It goes over time. It's like a fish going down a river. If you don't catch it in 10 minutes time, you need to keep on going and eventually you get it. But if you don't catch it the first time, you make a conclusion there's no fish in the river. But if you come back several times, you may catch it. So different scenarios. So that's why we do repetitive test follow-up on these patients, so that with a multi-marker, so that we have a greater chance of catching if there really is a cancer. Then it triggers off the follow-up.
Are you using blood or urine samples or both?
It's in the pancreas. We're right now doing blood.
Just the blood.
Like you were talking about, Jen, there's also all these ways to try to look at that. There's so many different, biomarkers that could be in the blood that we could leverage in particular patterns or in a particular way to say, this looks like cancer and this looks like cancer from one organ or another. For pancreas cancer. So, we're focusing on, microRNA, we're focusing on mutations within and methylation patterns within the cell-free DNA to look for pancreas specifically. There is another assay that is coming to commercial availability for pancreas that is looking at immunologic, the immune, it's sort of an immune signature to say this looks like that there's pancreas cancer, and tying that with some of the blood proteins. So there is a lot that continues to evolve. And I think, again, like for the audience, there's which test do you take and is one better than the other? They are each kind of trying to approach the view of the elephant in a different way. And maybe ultimately it's going to be this combination of things that we look at, all together or sequentially every, 6 months or once a year to really try to leverage how's the best way to see the fish that's floating around in the blood. You have to remember that in the old days, if somebody had a cancer and you wanted to see what was happening with it, you'd have to do an invasive biopsy. You'd have to try to go in over and over and say, is it the chemotherapy responding? Is this tumor, or is this just the shell of the tumor that's not alive? All of those kinds of things. So we really want to be able to do something non-invasive with a blood test to be able to track that in patients with cancer. The early detection is even harder because there's even less floating around potentially. So now we're looking at, with the ocean, and you're trying to catch a few fish in an ocean as opposed to, a ton of fish in a stream. So again, there's so much to be learned, and we're really part of the learning process. And that's something that we do at St. John's, that we're saying, and patients who are carrying along, saying you have to be understand that it's part of the road to learning. And this is where we're going, where we're hoping to go.
Right. And I think it's hard for doctors and scientists because, I have patients that I get positive testing on these urine tests for, let's say, prostate or bladder cancer, but all the other imaging is negative. And am I dealing with something that's microscopic? Well, how far do you go then to diagnose that or treat that? I mean, do you take out someone's bladder just because you've had a positive test? No, that's way overkill. So I think medicine is still trying to figure out between early diagnosis and early treatment, where does that start?
Yeah, to that question, right now in liquid biopsy, so-called, there's a big drive in many companies is early detection, what we call PanCan. And everybody is focusing, even around the world, can you walk in and have a blood test to tell you if you got cancer or not? These are still not that far away, but they still have to be validated. Some cancers can be detected early, but some can't. So just like your question you asked, if you have a negative, does that mean you're free? My approach is a little different, and I think you should have multiple tests. And then if it keeps on coming up, then it's worthwhile to further investigate. A single shot, as I described in the river and the catching of the fish, you just may not catch it at that time. And so it's better to have multiple tests. And if it keeps on coming up within a period, then something is really happening there.
Yeah, that's true. So what are you guys doing on the check to mutation? Can you explain to the audience what that is and how you guys are working together to track that?
Sure. And just to help explain to the audience, so, there are about 100 genes that we now know cause an increased risk for cancers, all different types of cancers. Some are very rare cancers, very unique, cancers of the neuroendocrine system that you get a very unique kind of tumor, or common cancers like breast and colon cancer. There are a couple of things that we do in people who have cancer that are really trying to find the genetic susceptibility, finding out even if they don't think that they might have a genetic cancer. For example, every colon cancer, every uterus cancer that is biopsied and found to be cancer at St. John's goes through a screening in the pathology lab to see if it's a hereditary form of cancer. Every patient who has a very specific type of breast cancer, or anyone who comes through our multidisciplinary breast program as part of their diagnosis for breast cancer, will be offered genetic testing. There's a lot of questions in the chat about kind of that. The other thing that we're doing to sort of help patients know whether they're even at risk is in our mammography, in our breast center for women who are coming in for mammograms. We're giving them a chat bot to ask them about their personal and family history and offer them genetic testing on that day. Every patient who has cancer of any kind who's being treated at St. John's or has in the past can come in and have genetic testing regardless of their family history. We're doing a walk-in education testing on demand to really help increase access and decrease barriers. For patients who are healthy, and there are a few questions in there about, how do you get to genetic testing? Do you ask your primary care doc? Should this be part of your routine annual physical? Absolutely. I advocate for people to bring their family history forward to anybody, all of their care providers, their gynecologist, their primary care doc. Have somebody and just reach out to us in genetics and say, is this something, hey, should I have genetic testing? And so we really help people to say, sure, this will be covered by insurance, or this probably won't be because of your family history, but you can still have genetic testing anyway if you want to incur that cost of $250. So that kind of helps. We're really trying to bring this out into the population and bring it out even broadly. I'm doing a few population studies, reaching out to our community and offering them comprehensive genetic testing regardless of their family history, to see how many patients are we finding. We know we're missing a ton of people who have genetic changes. The CHEK2, for example, is specific. It's one of a dozen breast cancer susceptibility genes. It increases your risk for breast cancer, for colon cancer. It may increase the risk for other cancers like kidney cancer. And so patients who are found, but it's pretty common. About 1% of people, Caucasian European people, carry genetic change, carry this CHEK2 change, and maybe 3% of people who have breast cancer, even without strong family histories. So when we find that genetic change, we do high-risk surveillance for breast cancer with MRI and mammogram. We offer them preventive medications. Depending now, there's a new genetic test that makes it even more personal. So if you have a CHEK2 mutation, not only is that genetic change in all the cells of your body, but what about the rest of your genome? You know how we talked about epigenetics and we talked about what's the genome? Well, your genomics are all the tiny variations in your DNA. When added together, might make you more influenced, more at risk for a disease, more protected for a disease, more responsive to a medication, or more likely to have a side effect. This is where we're really moving into trying to say everyone should be individualized. So with CHEK2 in particular, it turns out that we now have a genetic test that we can do after you carry the CHEK2 mutation to say, well, on the bell curve, you're at the lowest end of risk for CHEK2, or you're at really high, like your risk may be 6% or your risk may be 60%. And so how we take care of you might be different than how we take care of your sister, because this genomic influence is so different from every one person.
But what does the gene do exactly?
What does CHEK2 do? Do you really care what CHEK2 does?
Kind of, yes.
So CHEK2 is a check. So it is a checkpoint inhibitor. Basically, all of the genetic susceptibilities to cancer, for the most part, are in something called the DNA repair pathway. So we have tons of genes that help our DNA stay with really high fidelity and really high integrity every time that cell divides, right? Because it has to double, it has to split the DNA, has to go into each new cell, and has to be perfect every time. Otherwise, there's a mutation. You miss one letter, it's a mistake. Is that a mistake that's going to be critical to the cell or make that cell behave abnormally, or does it have no influence? But our body is designed to really to sanitize, high fidelity, keep our DNA super clean for every generation. So CHEK2 is part of that pathway to say, making sure that the DNA is absolutely perfect when the cells divide. Why a change in CHEK2 doesn't increase risk, just like a change in BRCA doesn't increase risk for every single cell. You're not at risk for every kind of cancer, even if you carry a genetic susceptibility. There is no genetic susceptibility that makes you at risk for every cancer. So how it behaves in each tissue and how the tissue and other influences, other genomic, epigenetic, hormonal influences affect that genetic change is different in the breast than it is in the skin.
Thank you. That was a very good explanation. Dr. Hoon, I'm going to kick this back to you. So as a scientist, with all these different methods of testing that are available, how do you in your lab start to narrow down what's best for each cancer? Does that question make sense?
So what we do is we focus on the clinical question from the clinician, be it early detection, or be it monitoring therapy, or be it monitoring reoccurrence. So we look at the markers that are best indicated. Like I said earlier, mutations may not be frequent enough to detect reoccurrence. So therefore, we have to look at methylation or microRNA to get a greater than 90% accuracy. Otherwise, you only got half a glass and you don't really know if it's true in terms of outcomes. So we focus on a lot of cancers we do here at John Wayne, like the GU, the GI, the melanoma, and the brain tumors. We have a large interest. We published on that. So we have a strong background in these cancers so that we know how to design the liquid biopsies towards these because we're familiar. We know in some cancers it's very hard to detect certain markers, so you have to do alternatives. So that's our approach, but we follow what is our clinical main source of patients, but we also do a lot of national, international collaborations that I work with. So it also varies on different cancers too. So it depends on the targeted need and the clinical question. It's usually when we first start on our program is what is the true clinical, unmet clinical problem? that we go after.
So that could be, for some cancers, that's diagnosis.
Right.
For some cancers, that is a treatment working. So you can use these tests before and after treatment to figure out whether the treatment is the patient's responding. You can use them to diagnose the to diagnose the cancer. And what really Dr. Gordon specializes in is using these tests to try to predict who's going to get the cancer and how to watch them efficiently to see if it ever, progresses or comes. Would that be about right?
So like a lot of times, like you do renal cancer, you do remove the tumor, but then you ask me, as we've been doing, what happens, when's it going to reoccur? Patient is disease-free, and so we test blood and urine for specific markers. So I detect those markers, then they come back to you and say, look, your patient is reoccurring somewhere, either in the original kidney or it's spread to lymph nodes or other organs. But then it gives you a heads up what you're going to do in the next treatment. The other thing is we didn't cover, we also look at tumors, mutation, methylation patterns, because that also tells you who's going to have aggressive disease and who's not, and who is likely to reoccur no matter, even if you take the tumor out. So that's also important. And also what drugs we'll use. Before we never had a lot of molecular targeted drugs. Now we have many. So it also tells you which is the best drug and how fast is that tumor likely to reoccur. In other words, even though you've taken out that tumor, because it has a bad, so-called bad genes, it's already spread systemically that we haven't detected yet. And then it'll just pop up. And so it tells us we should be ready for that tumor to reoccur.
Well, this has been a very fast hour. Thank you, Dr. Hoon. Dr. Gordon, any closing thoughts for us?
So I just wanted to make sure that, Jean, I'm sure we'll either send it out in the emails afterwards, a couple of these big population projects that we're working on. A lot of people are really worried about their risk or trying to understand their family history. So there'll be links to learn more about the Genome for Me project, which is this population screening for hereditary cancer and cardiovascular disease and how you respond to medications. The Gallery in Action study, which is the blood test that's looking at cancer detection, early detection through single blood test, the methylation assay, and then our program of screening patients who are coming in for mammograms. So I think that is a great place for people who want to learn more and try to help to be, their own best advocates for their personal and family histories and stewards of risk for their family. But we're all here, and I think what you heard was in terms of that continuity, right? It's from how do we find you if you're at risk? How do we take care of you if you're at high risk to make sure that you don't get cancer, or we find it as early as possible? And if you do get cancer, how are we going to, do everything we can at the point of care to make sure that your cancer journey is optimized in the most powerful and the best way? We have these virtual molecular tumor boards. So all the information that Dr. Hoon was talking about, all the information that Dr. Linehan was talking about, goes into like a group, committee, and all of that data, the sequencing, the blood markers, the imaging, and to say what's the best therapy for that person who has cancer. And we get input from actually all over the health system for those. So it's sort of leveraging the expertise of many to be very personalized in care.
Well, this is great. You guys are wonderful and such incredibly interesting information. And what's really incredible is that 5 years ago, the information would have been very different. Next year, we're going to have a lot of changes to this too. So, this education, we keep doing this, year after year. It's important to be able to explain some of the things that are changing to everybody. And so thank you all of you on the panel for your time today. That's fantastic. Yes, we are absolutely going to send out information on the Galleria in Action and the Genome for Me me. So for all of our participants today, or everybody that's been on this call and the one that the last webinar, we'll send out an email to everybody with not only the links to these webinars, but information on how you can hear more about these two studies that Dr. Gordon's been talking about. So thank you all for being here. This information on genetics in cancer screening and diagnosis and treatment is just, very life-changing if you're somebody at high risk. So the Cancer Institute, the St. John's Cancer Institute, has a long history of treating and researching cancer. And on these webinars, we highlight the work that our cancer teams do for our patients. We can't do this work without your support, though. So my job is to try and find support for our doctors and researchers. And so if you're interested in helping us in supporting the work that we do, I'd love to speak with you. You can shoot me an email, or I will be reaching out to everybody anyway. And I'd so appreciate hearing from you because it really, your support makes a huge difference to the work that we're doing. Our next webinar series is, we're going to have a series that starts in, I think, the end of April. It's called Treatment Options for Cancer. And we are going to be exploring 3 different areas. And so we'll have 3 webinars. One is going to be on immunotherapy and its increasing role in the first line treatment for lung cancer, melanoma, bladder, colon, breast, brain, and other cancers. The second webinar in the series will look at targeted therapies, and we talked about that. Dr. Hoon talked about that. Well, everybody talked about that more today. So as you've learned, the genomic analysis gives doctors and researchers critical information on the specifics of individual tumors, and that gives patients individualized treatment plans for their cancer. So you learn about how targeted therapies, drugs that block the growth of cancer by acting on specific molecular targets, how that's used in many cancer types. And our third webinar in the series will be about the combination therapies to fight cancer, using things like interlesional therapies or chemotherapy, immunotherapies. We've talked about targeted therapies to most effectively stop cancer in its tracks. We'll be sending information out to you shortly on this. And until we see you again, thank you for joining us, and we look forward to seeing you soon. Take care, everybody.